Well, hello and welcome, everyone. I just want to say thank you for joining us. I'm really excited about this because there's so much exciting news in diabetes in cats right now, and I can't wait to jump into this. I'm going to give everybody just a couple of minutes to join, settle in, get their audio and video going. And while we do that, I'm going to do a little bit of housekeeping. First of all, Dr. Cook has set aside a few minutes at the end for questions and answers. If you would be kind enough to use the Q&A tab on your Zoom dashboard and enter your questions there. Please enter your questions as we go along, other than trying to put them all in at the end, because that just makes it chaotic for me to try to find all of the questions. Also, please try to keep your questions to the scope of this webinar. If you have additional questions about diabetes or, not necessarily related to this, please talk to your veterinary care team. We would also very much like to thank our sponsor, our generous sponsor, for making this webinar possible. Boehringer Ingelheim has provided us with a total of 3 webinars this summer. We had one last month. We've got one coming up next month too. Watch our social media and your emails for more information about that. But they were kind enough to sponsor this webinar as well. And now I'd like to introduce our speaker. Dr. Audrey Cook is a graduate of the University of Edinburgh. She completed her internship at North Carolina State University and her residency in small animal internal medicine at the University of California at Davis. Dr. Cook is a diplomate of both the American and European Colleges of Veterinary Internal Medicine and is also recognized as a specialist in feline practice by the American Board of Veterinary Practitioners. After a decade in private referral practice, Dr. Cook joined the faculty of Texas A&M University, where she is now professor of small animal internal medicine, with particular interests in endocrinology, gastroenterology, and interventional radiology. I give you Dr. Cook.
Great. Thanks very much, Virginia. So thanks to all of you who are joining us. I'm going to just very quickly share my conflict of interest disclosure slide. I do have financial relationships with the companies listed here. And as you can see, I have a relationship with Boehringer Ingelheim and with Elanco, both of whom make products that are pertinent to this talk. I'd like to, again, add my thanks to BI for sponsoring these sessions. I think it's really, really impactful. So what we're going to do is start a little bit with the backstory of diabetes mellitus. And many of you may be very familiar with this, but I just think it's really important that we're all kind of on the same page as far as the physiology of feline diabetes. And that's going to help us contextualize this new exciting option for cats, which is the SGLT2 inhibitors. And then we'll take some time to talk about how those drugs work and how to implement them in practice when we're caring for our feline diabetics. So feline diabetes mellitus is a relatively common endocrine disease in cats. Its estimated prevalence is about 1 in 250 cats. And if you recognize that there are apparently 60 million cats in the USA alone, it does make you very aware of just how many cats are afflicted by this disease. Now, I've been a vet now for, I think, 35 years, and I would certainly agree that even in my career, the incidence of diabetes mellitus is increasing. And there's lots of interesting theories about why that might be, but it does appear to be somewhat lifestyle related. If you think back to the 1950s, where most cats lived primarily outdoor lives and caught a lot of their own food, diabetes mellitus was pretty uncommon. You contrast that with 2024, where most of our cats, for very good reasons, live indoors, and therefore we are responsible for feeding them. And it could be that some of the models we've adopted for feeding our cats is actually driving them down the road to diabetes mellitus. Diabetes is a very, very treatable disease. And as many of you are aware, a substantial proportion of cats can actually go into what we call diabetic remission, which traditionally is classified as a cat that no longer needs any insulin for its diabetes. Probably going to have to redo the classification of diabetic remission now that we have some other treatment choices on the table. Now, very similar to the situation in human medicine, insulin resistance is probably the primary driver of diabetes mellitus in most of our cats. It's very hard for us to classify diabetic cats as reliably as they do classify diabetes mellitus in people. But clearly, more than 50% of cats have very, very clear similarities to type 2 diabetes mellitus. Type 2 diabetes mellitus is sometimes referred to as non-insulin dependent diabetes, which maybe isn't a particularly helpful terminology because some patients do actually require insulin. But the big difference between type 2 and type 1 is individuals who have type 2 diabetes mellitus usually have viable beta cells at the time of diagnosis. They're just not able to make enough insulin to keep blood glucose under control, but some beta cells are still there. If you're a type 1 diabetic, those cells are pretty much gone. So I want to take a little bit of time to talk about those bolded phrases that I used, because I think the phrase insulin resistance and the phrase glucose toxicity can be a little bit confusing. And I think it's really important that we all kind of understand what we mean when we say that. When we say insulin resistance or insulin sensitivity, which is kind of the flip side, what we're talking about is how much insulin it takes to get the job done. And so an individual who is sensitive to insulin needs just a little bit of insulin to keep blood glucose under control. An individual who's got insulin resistance requires significantly more insulin to keep blood glucose under control. And remember, insulin does an awful lot more than just simply regulate blood glucose. It's a major metabolic player when it comes to energy storage and appetite. So we focus a lot on glucose, but that's really undervaluing a lot of the other activities that insulin is responsible for. So think about insulin resistance. This is the model that I share with my students, which is just a very kind of broad overview of the things that can impact how sensitive and responsive we are to insulin. And so other hormone diseases can make us insulin resistant. And so from the feline perspective, we worry in particular about being hypothyroid, having acromegaly or growth hormone excess, or Cushing's disease. Those are all very well recognized causes of insulin resistance. And then another very big category is inflammatory diseases. And these don't have to be infectious, although they could be, like chronic stomatitis, chronic dental disease. These could be sterile inflammatory diseases like allergic dermatitis or pancreatitis, inflammatory bowel disease, even osteoarthritis. Anything inflammatory that triggers the release of cytokines tends to cause some degree of insulin resistance. Obesity is basically another endocrine disease. I probably should move it actually out of its own box and put it as an endocrinopathy, because that's the culture now from the human perspective. But simply having significant adiposity, again, is going to make you insulin resistant. And that's partly to do with the inflammatory nature of obesity and partly to do with all the hormones that are made by adipose tissue. And then sometimes as doctors, we trigger insulin resistance by putting patients on steroids or progestins. These drugs are going to powerfully antagonize the impact of insulin. So a cat could have one factor, a cat could have 4 of these factors. But what happens is we're going to have to get increased insulin secretion once we're insulin resistant. And so in order to keep our glucose in check, it just takes more insulin than a healthy pet to just keep that blood glucose in check. And blood glucose might be a little bit more robust in a patient who's insulin resistant than a patient who is insulin sensitive. So there's a bit more glucose maybe hanging about. When we have a patient who's putting out more insulin, they also co-secrete a molecule called islet amyloid polypeptide, or amylin. And IAPP, or amylin, is probably got a really important physiological responsibility as far as regulating appetite. It's a little bit of a mystery as far as its purpose, but it has a purpose. And unfortunately, that amylin can actually kind of get clogged into the pancreas and cause pancreatic amyloidosis. And that then compromises insulin secretion. Now, not every species is vulnerable to this. If you are a dog, then you make very soluble amylin. And so dogs with insulin resistance don't tend to become diabetic. But cats and people and macaque monkey have very insoluble amylin. And so those are the species that tend to drive themselves towards type 2 diabetes. You've put that amylin into your pancreas, it's going to make it more difficult to produce insulin because now the pancreas is less healthy. You lump that in with your insulin resistance, and now we have a patient who is significantly deficient in insulin. They might be making some, but it's not nearly enough, and blood glucose concentrations are now moving up and are moving out of the reference range. We now have a patient who is hyperglycemic. So the second term I want to talk about is glucose toxicity, and that is the effect of hyperglycemia on cells and tissues. And I can remember when the term glucose toxicity first appeared, and my first reaction was, well, we see lots of diabetic patients and the blood sugars are 260, 310, and we're not sweating it. Toxicity must mean blood sugar is, I don't know, 600. It's not true. The standard in human medicine is that a blood sugar over 200 milligrams per deciliter. And so that's not horribly far out of the human reference range, puts you in the glucose toxic model. And I think that the same is probably true for our feline patients. And so once that blood sugar is over 200, it is doing damage. The impact of that damage is going to be affected by how high the blood glucose is. So yes, 600 is significantly worse than 210. But 210 is bad. It's also impacted by the duration. So spiking a blood sugar briefly to 600 isn't a big deal, but sitting with a blood glucose of 230 for weeks and weeks or months and months is a big deal. And the actual process by which that highest blood glucose causes damage is an area of hot research and debate from the human perspective. The mechanisms are complicated. There's probably more than one process going on. Does appear to be related to glycation of protein, and so proteins are physically damaged in a hyperglycemic environment. And there's also pretty good evidence that there's disruption of organelle function. So some of the organelles that you need to keep your cells alive and functioning are impaired in even a modestly hyperglycemic environment. Now, the effect that the hyperglycemia has is somewhat dependent upon the cell type. And so a lot of us who deal with diabetic cats are very aware that prolonged, even moderate hyperglycemia in some cats will result in damage to the nerves, the neurons, and we'll get a peripheral neuropathy. This is a huge issue in humans with both type 1 and type 2 diabetes mellitus. Very, very painful and very, very damaging. We're not sure if it's a painful condition in cats. They don't seem to manifest pain the same way, but they certainly can lose function. Now, hopefully this video is going to play because you never know, but this is a video that a colleague shared with me. This cat presented to his primary care vet because he couldn't jump. The cat had been walking funny for a couple of months, and then it hit the point that this poor cat could no longer jump onto the furniture, and that's what triggered the owner to seek veterinary care. Now, that cat was probably hyperglycemic for weeks and weeks and months, and so some of the damage that's been done to those nerves is unlikely to be reversible. The other cell type that is particularly vulnerable to glucose toxicity, ironically, is the pancreatic islet beta cells. So those are the cells, as you know, that actually make insulin. And so painfully ironic that one of the cells that takes a significant hit in a hyperglycemic body is the pancreatic beta cells. And what initially happens is they get kind of blunted to glucose. And so rather than being able to reliably detect modest changes in glucose, it's like they've got their earpods on and they really can't recognize what's happening with glucose until glucose has got extremely high. And so they become desensitized to hyperglycemia. They just don't respond like they should. They have a blunted response. And then what can happen is the cells actually start to die. They undergo what's called an apoptosis, which is like a programmed cell death. They're not taken out by another inflammatory cell. No, the cell just basically unplugs itself and the cell will die. Now, we haven't got too much time to talk about this, but I could talk about glucose toxicity for hours because I think it's absolutely fascinating. But I do want to share with you one of the studies that looked at this in cats. And this is an old study, but even as I talk about it now, I don't know, 15 years after it was published, I still feel the same sense of anxiety that I experienced the first time I read it, because for me, this was a seismic shift in how I thought about glucose toxicity. And this was a wonderful study done by one of the teams out of Europe, Zinni and others, and was published in 2009. And what they did was they took two cohorts of young, healthy cats. These cats were less than 2 years of age. They were purpose-bred, lean, muscular, good-looking, about 18-month-old cats. And they were put into a study group and a control group. And what they did with the study group is they put in jug cats and they infused enough 50% dextrose to keep their blood sugar over 450, between 450 and 540. And they did that for 10 days. So for 10 days, these cats are sitting in cages. They've got their jug cath in, the dextrose is being pumped in, their blood sugars are clamped at 450 to 540 milligrams per deciliter. The control cats were just given saline through a jug cath, so nothing different for them. What they saw in the glucose-infused cats was an initial, as you'd expect, massive spike in insulin. As soon as they turned on the dextrose infusion, insulin production screams up in an effort to try and blunt the hyperglycemia. But by day 5, essentially zero. The beta cells gave up, just held up their hands and thought, you know what, forget it. I'm not wasting my time trying to deal with this hyperglycemia. And then when they actually harvested their pancreases and took a look, we can see the image on the left side of your screen, which is a lovely healthy islet cell, and that's taken from one of the cats who was given the saline. And then the image on the right is a portion of the pancreas from one of the cats who received the glucose. The 50% reduction in beta cells. When they actually stained for insulin production, that was down 80%. So perfectly healthy cats, 10 days, only 10 days of hyperglycemia, 80% reduction in insulin staining, and 50% loss of cells. This is glucose toxicity. Doesn't take weeks and weeks and months. It was metabolically evident by day 5 when their pancreases quit making any insulin. And by day 10 on histology, we've got decimation of the normal islet architecture. So glucose toxicity is all about blood sugar being over 200. And so if we're going to try and reverse glucose toxicity, we have to get blood sugar below 200 milligrams per deciliter. Now, cells that have been lost will not return, but the surviving cells can actually regain the ability to secrete insulin. So in a hyperglycemic environment, we've got a couple of target beta cells here. One of them is going to undergo apoptosis. That cell is done. It's not coming back. The other cell is going to stop responding to the insulin. It's going to just lose the insulin sensitivity. I think in terms of pulling the cardboard box over its head and thinking, I'm not coming out until conditions improve. Now, if conditions don't improve, those cells that have shut down will also undergo apoptosis. They were the more resilient of the beta cells, but they have a limit to their resilience. If, though, we can achieve euglycemia, if we can get blood glucose concentrations to fall below 200, we can actually get those cells that are hunkered down and frightened and traumatized, we can actually get those cells to step back up, undergo functional recovery, and start again to secrete insulin. So we've known about this phenomenon for some time because we do know that a substantial proportion of cats who are treated well for their diabetes mellitus can become insulin independent. They can recover from an insulin dependency. And we've referred to this as diabetic remission. And in order to achieve diabetic remission, we've all been taught we need to mitigate our insulin resistance. So think of all those things that make a cat not respond well to insulin and knock off all the ones you can. So have the cat lose weight, deal with the bad mouth, get it off the glucocorticoids, really think about reasons for insulin resistance and modify the diet so that's a benefit as well. And then we have to reverse the glucose toxicity. We have to get the blood sugar below 200. And to do that, we put these cats on insulin. And for a fair portion of cats, that's been a reasonably successful approach. Not every cat by any means, but many cats do very well on insulin, and a substantial proportion of cats who are treated with insulin, particularly if they're managed aggressively, will undergo remission. But maybe we have some other options. And so I'm sure we've all had this question when we've talked to owners about diabetes and drawn some parallels to type 2 diabetes in people. There's not one of us that hasn't heard this question, which is, okay, I get it, but why can't we use our oral hypoglycemic drugs in our diabetic cats? Well, we've all wanted to do that for a long time. And the reason for that really is And understandably, for those of us in the medical profession, giving a cat an injection is not a big deal. But for many owners, issues with syringes and needles are daunting, very, very daunting. And they've got to change their lifestyle. They've got to be very committed to treating the cat on a time schedule and be very responsible about changing their lifestyle to accommodate the cat. And then we have to talk to cats about the risk of hypoglycemia, which for many owners is truly terrifying. The thought that they might, in all good faith, give their cat an insulin injection in the morning, and then the cat vomits up the breakfast and doesn't eat, and then they come home to a cat who's having a hypoglycemic seizure is terrifying. So this is a list of the oral hypoglycemic agents that are licensed for use in people. And it's a pretty interesting list because these drugs work in very, very different ways. The sulfonylureas are one of the big leaders in oral diabetes management. And this would include drugs like glipizide or glucotrol is the brand name. That was looked at in the 90s by a team at UC Davis in cats with diabetes mellitus. And I remember being peripherally involved in some of the glucotrol cats. Occasional cat went into remission. Vast majority of cats didn't do particularly well. And there were concerns about hepatic toxicity. The biguanides, that's one of the very oldest diabetic drugs out there. And that includes metformin, which is still enormously impactful in human diabetes and in many treatment algorithms is still the #1 choice for type 2 diabetes in people. Very small study performed again at UC Davis looking at metformin in cats. That study was terminated very quickly because one cat died. Responses on the few cats that were treated were generally very poor, and then one cat died, and that was the end of looking at metformin in cats. The glucosidase inhibitors are oral drugs that actually block the action of brush border disaccharidases. So these enzymes are required for us to fully break down disaccharides into monosaccharides so that they can be absorbed across the gastrointestinal tract. So if you block those enzymes, you're going to absorb less carbohydrate. They do have a small benefit in some individuals, some people with type 2 diabetes mellitus, but studies in cats have been very, very disappointing, very modest effects, if any effect at all. And now that we're such proponents for low-carb diets in cats with diabetes mellitus, as a general rule, I really don't think that there's a role for the glucosidase inhibitors. The dipeptidyl peptidase 4, the DPP4 inhibitors, these are also oral drugs, and they are designed to prolong the action of endogenous GLP-1. GLP-1 is the pancreas-loving incretin, and so GLP-1 analogs are routinely used. They're injectable for human type 2 diabetes. And then there's this oral drug that prolongs the action of our own GLP-1. Has been looked at in primarily obese cats with little effect and really doesn't seem to show a lot of promise at all. And so sulfonylureas disappointed, the biguanides really disappointed, the glucosidase inhibitors, didn't do very much. DPP4 inhibitors, a modest effect at best. But the SGLT2 inhibitors, that is the oral anti-diabetic drug that has just totally flipped on its head how we think about feline diabetes mellitus. So SGLT2 stands for sodium glucose cotransporter, and there are a whole series of proteins that fall into this category. So there's several in this family, essentially. But their job, no matter where they are or exactly who they are, is simply to move glucose across membranes. That's what they do. Glucose has to be portaged across a membrane. It's not fat soluble, so it cannot get into a cell unless it is specifically transported. There are several types of sodium glucose cotransporters in various locations, but the ones that are of interest to us are SGLT1, which is found in the GI tract, and that's really important for bringing in digested glucose when we've eaten a meal. SGLT1 is also in the kind of second part of the proximal convoluted tubule of the kidney. And SGLT2 is what we're really interested in, and that is only found in the first portion of the proximal convoluted tubule of the nephron. And SGLT2 is a major player in the reabsorption of filtered glucose. So as I'm sure you can remember, glucose being a tiny molecule is freely filtered. So when the blood moves through into the glomerulus and the watery part is filtered, any glucose molecules that are floating through are going to just fall proportionately with that watery part of the blood across the and into the glomerulus. And so we're going to get glucose entering the tubule. Well, glucose is important, and Mother Nature doesn't want us to waste our glucose if we're healthy. And so we have these co-transporters that are designed to bring glucose back. They grab a sodium molecule while they do it. So their job is to pump that glucose out of the filtrate. And under normal circumstances, over 90% of filtered glucose is reclaimed with the SGLT2s. The remaining 10% is picked up by the SGLT1. The only place that we can absorb glucose in the nephron is that proximal convoluted tubule. So any glucose molecule that manages to avoid the SGLT2 and then dodge the SGLT1 is going to end up getting its way into the loop of Henle, and then it's a straight shot out. There's no other way that glucose can be reabsorbed. And so if we think about what happens, a little glucose molecule comes on through, it's going to enter that proximal convoluted tubule, it's going to hit that SGLT2 molecule, and it's going to be reclaimed. This schematic just shows that in a little bit more detail. And so on the left-hand side here, we've got the blood, and on the right-hand side, we've got the filtrate. And we can see that blue SGLT2 receptor sitting there, waiting to pick up a sodium molecule and a glucose molecule, and then using some energy, pump those through into the cell, and then using another glucose transporter, going to go ahead and pop that glucose back into the blood. And so that glucose is then reclaimed. But if we inhibit that, if we put an SGLT2 inhibitor into the mix, it's going to turn off that process. And so that glucose is no longer going to be absorbed and returned to the blood. Instead, what we're going to get is that glucose appearing in the urine. That glucose is going to be lost from the body. So we think about the SGLT2 inhibitors. This is a big drug class. It's a very important drug class from the human perspective. Anything that ends in flows in is going to be an SGLT2 inhibitor, and the team is referred to as the gliflozins or gliflozins. There's a lot of debate about how to say this, but I have settled for gliflozin because I checked it on glucose, and that was how on Google, and that was how Google said to say it. So if you are taking an SGLT2 inhibitor, much of that filtered glucose is excreted. Now, if your blood sugar is high, that's a really great advantage. But even if your blood sugar is normal, it can be a huge advantage. What's interesting about using a SGLT2 inhibitor to waste glucose from the body is that there's essentially zero risk of clinical hypoglycemia, because if your blood sugar levels are moving down because you're purging glucose, you're going to release counter-regulatory hormones like glucagon to boost that blood sugar back where you want it to be. There's also really good evidence that if blood sugar is moving a little bit low, the SGLT1s will kick up activity and will reclaim a little bit more glucose from the urine. Now, there are numerous gliflozins licensed for type 2 diabetes in people, and I've got a picture here of Jardiance empagliflozin, which is made by BI, and that's the market leader for type 2 diabetes mellitus now in the human field. Lots of adverts on TV with people cheerfully dancing and singing, taking their Jardiance. Look at it from the human perspective, there are kind of some rules and guidelines. And so gliflozin they're only licensed for use in type 2 diabetes mellitus. They can only be used, therefore, in people who have some insulin production. Now, there are some protocols for adding these to exogenous insulin for people with type 1 diabetes mellitus. But if they're being used as the sole agent, then the human has got to be able to excrete a little bit of insulin. Not a lot, just a little bit. You can also find products where gliflozins are combined with other oral anti-hyperglycemic drugs. So by purging surplus glucose through urine, we're going to get improved glycemic control. And I'll share with you some of the data of just how quickly we can take a hyperglycemic patient down to a euglycemic patient by starting a gliflozin. It is pretty stunning how quickly that blood sugar will improve when more glucose is being lost in the urine. These drugs also support weight loss. There's probably several mechanisms for that, but you are simply losing even more glucose in the urine, and so that's going to support weight loss. One of the things that's really encouraging, though, is if we can bring that blood glucose down under the magic 200 and do that fast and consistently, then we're going to support beta cell function and recovery. And so those beta cells that have given up and were just waiting for the end will recognize that euglycemia has been achieved, and then they can step up to the plate and they can respond more appropriately, and they can produce a bit more insulin than they were managing to do so before. So now when somebody says to us, why can't we use oral hypoglycemics in our diabetic cats? We can. We have some new solutions for feline diabetes, which is tremendously exciting. So there's a couple of products that have become available in the last 12 to 18 months. The first one to hit the market was made by Elanco, and that is bexigliflozin or Bexacat. This has been FDA approved for new feline diabetics. Bexacat comes as a 15 milligram tablet, and the dose is the same irrespective of the cat's body weight. It is not suitable for cats. Oh, I have a typo. I do apologize. Not suitable for cats who are less than 3 kilos, 6.6 pounds. So typo on the slide. I apologize. Should not be used in cats who are smaller than 3 kilos. It can be given in the food, or the cat can be directly pilled. The other product is Sunvelga, which is velagliflozin oral solution. That's made by Boehringer Ingelheim. And this, again, is FDA approved for new feline diabetics. It's an oral solution. It is 15 milligrams per ml. It's given once daily. Again, the medication can be placed on food or put directly into the cat's mouth. And this is dosed based on body weight. The dose is 1 mg per kg. And so this is not a flat dosing schedule. This is a body weight adjusted dosing schedule. Now, whenever a new drug comes out, we always want to hit the literature and make sure that we have an understanding of what studies have been done, what data is available, so we have a good grasp. And I've listed here 3 references that I'll be talking to as I show more slides. So reference 1 is the paper by Had and others that was published in the Journal of Veterinary Internal Medicine in 2023. And this was looking at bexigliflozin, and 84 cats were given the drug in that study. The second reference I'm going to talk about is Behrend et al. And actually, I'm one of the authors on that paper. And this is looking at velagliflozin. The actual final manuscript is still in press, but is very close to being published. So the only published data right now from that study is published in abstract form, but is available on the reference I've cited here. But stay alert for the final version of that big manuscript. I'm hopefully hitting the library shelves very soon. And that reported on 252 cats that had received velagliflozin. And then there was a very recent publication, actually literally came out within a few weeks. And that was a European study looking at velagliflozin. That is what I'm referring to as reference number 3, led by the fantastic Stein Nielsen. And that was a very interesting study, because that actually was a study that put velagliflozin head to head against insulin. 61 cats got velagliflozin, 66 cats got insulin. And so that was a really nice comparison study. So I'm going to leave that slide up just for a second in case somebody wants to take a little screenshot, because I do think it's very, very helpful to access those resources and read some of that data for yourself. I'm going to try and summarize it, but I have not got time to go through all 3 of this data sets in tremendous detail. So we look first at the efficacy of the SGLT2 inhibitors. What is most impressive is the really pretty rapid improvement in glycemic parameters. If we look at velagliflozin, 90% of cats had a blood sugar less than 230 after just 30 days of treatment. And I don't think those words have ever been said for cats receiving insulin. In the Bexa study, by 8 weeks of therapy, the average blood glucose in that cat cohort was 161 milligrams per deciliter. If we look at normal fructosamine on day 56, 45% of the Bexa cats had normalized their fructosamine by day 56, which is impressive. We're not talking about getting a fructosamine into the well-done diabetic range. We're talking about getting a fructosamine into the healthy cat range. On day 180, so after 6 months of therapy, 81% of the cats still on veligliflozin had a normal spot blood glucose. And again, 81% of cats on veligliflozin at 6 months of treatment had a normal serum fructosamine. Again, that's a fructosamine, not in the well done with your diabetic range, but in the clinically normal non-diabetic cat range. And so again, those words were never said for cats receiving insulin. This is some information from the bexigliflozin paper, and I utterly and totally love this slide because what it's showing here is the breathtakingly dramatic response to a single dose of bexigliflozin. So the axis on the y-axis is showing us blood glucose concentrations, and then we've got time. So we've got 0, 2 hours, 4 hours, 6 hours, and 8 hours on the x-axis. And then the first steep line, that is day 0. So this is what happens when a cohort of diabetic cats gets a dose of bexigliflozin. You can see that within 8 hours of that dose, the average blood sugar has dropped below 200. It's an absolutely stunning response. And then if we look at what happens on day 14, day 28, day 56, and day 84, pretty much the same shape for day after day after day. Things might have got slightly lower as the study progressed, but basically by 2 weeks into this, the cats had a blood sugar that was consistently below 200. I mean, this is absolutely beautiful data. This is, again, it's once daily dosing. The cats are getting the dose at the 0 hour. And so it tells us that we're getting 24-hour control of hyperglycemia. The slide here is taken from one of the big US veligliflozin study with the 252 cats. And this slide shows blood glucose is at several time points. Now, in the Bexicat study, they only looked at brand new diabetics. In the veligliflozin studies, both insulin treated but poorly controlled and naive diabetics were allowed to be enrolled. In both of those studies, both the US veligliflozin and the European veligliflozin, about a quarter to a third of cats were unsuccessful insulin-treated diabetics, meaning they're on insulin, but they're still hyperglycemic, they've still got a high fructosamine, and they've still got clinical signs of diabetes. And so for the data we're showing here, the naive versus the pre-treated are separated out, with the naive shown as the gray bars and the pre-treated cats shown as the black boxes. So the first data set on the left is from the screening visit, and then we can see values at 1, 2, 4, and 6 months of veligliflozin therapy. And we've got the reference blood glucose intervals shown by the dotted lines. And as you can see, the vast majority of these cats have fallen into the blood glucose reference range very, very quickly in the course of the study. Now, great news as far as achieving euglycemia, and then always the worry is, well, what about hypoglycemia? Was that a concern in these cats? And pretty much no. And so the lowest blood glucose recorded in any of the 84 cats on the bexigliflozin study was 54. That was the very lowest they found. In the veligliflozin study, and remember, this is 252 cats who are studied for up to 6 months. And so you can imagine the number of glucoses that were run on these cats. There were thousands of glucose readings on this 252 cat cohort. 9 cats were ever clocked to get a blood sugar below 60. 9 cats on 15 occasions were found to have a blood glucose below 60 milligrams per deciliter. It was the average of those hypoglycemics was 57, and the lowest blood sugar recorded at all was 42. I would point out that almost all of those blood glucoses were measured on the alpha track, and many of us feel that when the blood sugars are moving at the bottom end of the reference range, the alpha track may read slightly low. In the European veligliflozin study, where we've got the head-to-head in the cats taking lente insulin versus the cats getting veligliflozin, they talked about hypoglycemia in terms of a blood glucose less than 63 milligrams per deciliter. How often did that happen per 91 days? And so that happened 1.17 times for cats receiving insulin, and it happened 0.21 times, so less than 20%. For the cats who were receiving the veligliflozin. There were 5 episodes of actual clinical hypoglycemia in the European Vela study, and that was only reported in cats on insulin. None of the cats on veligliflozin had any clinical hypoglycemia, only biochemical hypoglycemia. But in the insulin-treated cohort, there were 5 episodes of clinical hypoglycemia. So to date, in the literature we've got reported, no episodes of clinical hypoglycemia have been reported in a cat who was only receiving an SGLT2 inhibitor. Again, those words were never said about any insulin ever in a feline study. The other issue that was looked at very closely in the safety evaluation of bexigliflozin and velagliflozin was diabetic ketoacidosis. And the incidents seemed to be relatively similar. And so in the Bexa cat, about 5% of Bexa study, about 5% of the cats on the bexigliflozin had diabetic ketoacidosis. In the US VELA study, 5% again of newly diagnosed diabetics had DKA. The likelihood of DKA was higher in cats who had previously received insulin. And then in the European study where the velagliflozin is going head to head with insulin, there was a 7% overall incidence in the cats who are receiving velagliflozin. I did not see where that data was separated out for newly diagnosed diabetic cats versus insulin-treated cats. One of the things that I think has caused some confusion and consternation in the veterinary world is that the diabetic ketoacidosis that manifests most often in cats who are receiving an SGLT2 inhibitor is what's called euglycemic DKA. This means that we have a cat who is unwell and has metabolic acidosis and has significant ketonuria or systemic ketonemia, but the blood sugar is less than 250. And so what's happening in these cats is that the drug is bringing down the blood glucose, but the beta cells are not able to make just that little bit of insulin that you need to turn off ketosis. And it takes yay much insulin to stop ketosis and this much insulin to achieve euglycemia. So if we bring your blood sugar down and you just can't even make that little bit of insulin, your pancreas is just too short, then you're going to potentially manifest euglycemic DKA. This almost always happens within the first 14 days, often actually within the first 7 days, but usually within the first 14 days. Other adverse events that were reported, so changes in stool consistency. For FDA reasons, if you ask somebody to look at their cat stool and they say the stool is softer, then that is clocked as being an episode of diarrhea. Usually it is very, very subtle change in stool consistency, but the occasional cat was taken off of SGLT2 inhibitor because of intractable diarrhea. 50% of the cats who got bexigliflozin vomited at least once over the course of that study, which was 84 days. 1/3 of the cats who got velagliflozin in the US study vomited at least once during the 6-month study. And then urinary tract infections, hard to interpret the meaning of this because a significant proportion of cats had a UTI at the time of diagnosis. And the term UTI has been used without any effort to distinguish between actual true urinary tract infection with clinical symptomology versus subclinical bacteriuria, because these cats were having urine cultures pretty regularly. I want to move on to talk about patient selection. Even though velagliflozin was looked at in pre-existing diabetics, both in the US and the European study, I want to really emphasize that both bexigliflozin Bexacat and velagliflozin oral solutions, Senvelgo, are only FDA approved for untreated, naive diabetics. These drugs are not licensed for cats who've been receiving insulin. Good candidates for SGLT2 inhibitors should be feeling well apart from clinical signs of diabetes mellitus. They should be eating and drinking and happy and hydrated. There's some discussion about what degree of chronic kidney disease is acceptable. I would certainly be very happy if the creatinine was less than 2. I would consider using an SGLT2 inhibitor up to a creatinine that was 2.8, which is the top end of IRIS stage 2, but I would really think about it. Suitable cats should have no significant comorbid conditions such as active pancreatitis or untreated hyperthyroidism, and then really no evidence of ketosis. Now, I'm going to take a few slides to talk about what I mean by ketosis, because this isn't something that we've really focused on all that much in our happy, smiley diabetics in the past. When we're thinking about the generation of ketones, that's a reflection that we're not making enough insulin. And There's 3 ketone bodies that are made by cats, but the most important by far is this one called beta-hydroxybutyrate, or BHB. So if BHB moves up, it tells us that we have excessive lipolysis, which is because of a lack of insulin. And really, it's like when your ketones are moving up, it's kind of like the check engine light or the fuel tank empty light coming on in your car. And when we're seeing that light come on, you don't know if you could go a little bit longer and maybe make it home, or if you just need to get gas. But the safest thing is probably just go ahead and get gas. You're heading for trouble. Now, I'm old enough to have been very happy simply using a dipstick to identify patients who were ketotic. The urine dipstick, though, is really not very good, and it identifies acetoacetate and acetate, particularly acetoacetate, and doesn't measure at all beta-hydroxybutyrate. And that is the one that we care about. BHB is the one that's actually most important, and so we can't measure that. If you get a change on your dipstick, you can bet your bottom dollar that blood BHB is over 1 millimole per liter. Some units talk about milligrams per liter, but millimoles per liter is the one that I prefer to use because that's what the US handheld machines will display. Having said that, by the time the urine is dipstick positive, the blood could be 2.4 or 3.1. We don't know. We know for sure it's going to be over 1, but how far over 1 it is before the dipstick changes in the urine, we just don't know. Versus, you can actually measure blood BHB using a ketone meter. These machines are inexpensive. They're like a glucometer. There's been some nice studies to validate specific brands for use in cats. You really know where you're sitting. I strongly think every single practice needs to invest in a monitor. In US terms, it's less than $50. The test strip is less than $1.50. We want to look for ketones each time we evaluate an SGLT2 inhibitor cat. And it's actually much easier to get a spot of blood from the ear than to collect urine each time. Now, you can put serum on a dipstick. And so there's ways to try and pick up on what's happening in the blood. But really, we've got the exact same issues as we have with looking at urine on a urine stick, in the sense that we're not measuring blood hydroxybutyrate, and that is the one that matters. The thing I want to touch on when we're looking at using these in our practice is what to do with diet. I get a lot of questions about that. We don't know the impact of diet on SGLT2 inhibitor responses. In human medicine, they say specifically do not restrict carbs if you're taking an SGLT2 inhibitor. But people and cats are very, very different as far as their relationship to carbohydrates. I do think it's appropriate, based on what we know at this point in time, to transition diabetic cats to a low carbohydrate diet. I would say, though, that I would start the SGLT2 inhibitor first, do a couple of weeks on that, make sure there's no problems, cat's eating fine, we haven't confused things by changing food type, get them cruising on their new medicine, and after a couple of weeks, then go ahead and switch them to one of the so-called diabetic diets. As far as monitoring our patients, the key concerns are as they have always been. We want a good body weight, we want limited clinical signs, we want a happy cat, we want to reverse things like diabetic neuropathy, and then most important of all, we want a satisfied owner. Now, I've sketched up on here my current suggested monitoring scheme. And so obviously, you're going to do some good evaluation when you first diagnose them. Then you want to see the cat back, I think, day 2 to 3. I would say back again day 7 to day 8, and then back again day 14. Now, we know from the field studies that most cats that experience significant issues, particularly DKA, are going to do that in the first 2 weeks. So those first 2 rechecks are really important, as this is the time frame when we're most likely to identify a cat that needs insulin. And we want to spot those cats before they become clinically unwell. And obviously, anytime the cat's not feeling well, the cat should come in for an evaluation. When you look at these cats, just do a spot check blood glucose. We've seen the glucose curves in cats on these drugs, and it's a flat line. So a spot check is all you need. You can do a fructosamine. That's a very nice way of trying to assess what's happening at home. And then I would say every visit, we just simply measure a blood BHB. And these are the guidelines I'm using. Now, I might be a little bit on the cautious side. I've got some colleagues who now think that if the cat is feeling fabulous, the BHB is moving above the 2.4 millimoles per liter, it's okay to continue, just monitor them very closely. I absolutely respect other people's opinions on this. The suggestions I'm making here are deliberately quite conservative. BHB less than 1 millimole per liter, you're fine. BHB 1 to 2.4, particularly if it's trending upwards, maybe take a peek in a couple of days. BHB more than 2.4, my feeling is you probably need to consider insulin therapy. As far as troubleshooting, if you do get a patient who experiences the diarrhea, it will usually self-resolve. You can certainly consider probiotics. Switching to a low carbohydrate diet might actually help because the diarrhea is probably something to do with a little bit of inhibition of GI SGLT1s. And so if they're on a high carb diet, they're not absorbing some of those glucose molecules as well, and that's going to cause an osmotic diarrhea. You could certainly add kale in things just to change stool consistency. If the diarrhea is a game changer, clients can't take it, then you're going to need to switch to insulin. Bear in mind, though, it can take 2 or 3 days for an SGLT2 inhibitor effect to completely wear off. And so hold off on insulin until the cat is proven to be hyperglycemic. Don't just stop the SGLT1 and give insulin because that cat would be vulnerable to hypoglycemia. If you have a cat that is persistently hyperglycemic, but feeling okay at day 30, I would tend to say you're probably not going to get a response. So that's usually even if the cat's feeling okay, if the blood sugar is over 300, this is not a good choice for this cat. And that's the time at which I would say stop the SGLT2 inhibitor and switch to insulin. Now, because that cat is still hyperglycemic, you can just go ahead and give insulin the following morning. Now, I want to take a little bit to talk about DKA because that is something that always triggers a lot of questions. And so just a reminder, DKA routinely diagnosed in untreated diabetics or diabetics on insulin who aren't getting enough. Lack of insulin results in a sustained hyperglucagonemia, and glucagon usually keeps lipolysis in check. When insulin is too low, there's not that little bit that you need to keep glucagon in check. Glucagon runs amok. We get crazy uncontrolled lipolysis. We make boatloads of ketones. We get metabolic acidosis. We can't use those ketones. We end up getting sick. And so we have a patient who is systemically unwell. They're kind of poisoned. Their BHBs are over 2.4 millimoles per liter, often significantly higher, like 4 or 6 is not unusual. They're going to be ketonuric at this point, and they have a metabolic acidosis. Now, traditionally, these cats were all hyperglycemic. And so we expect blood sugar to be 400 or 500 in our DKA cats. But if a cat is on an SGLT2 inhibitor, not able to make just that little bit of insulin we're asking it to make, we're going to get euglycemic DKA. So they're ill, they're ketotic, they're acidotic, but their blood glucose is less than 250. And euglycemic DKA is a life-threatening complication of SGLT2 inhibitors in both people and cats. Sustained insulin deficiency will result in DKA irrespective of blood glucose concentrations, and the only way to turn off ketosis is with insulin. As I said, most likely to occur in the first 2 weeks, which is why really good screening and appropriate monitoring is key. Now, as far as treating euglycemic DKA, they're going to need fluids for their toxicity. They need insulin, CRI is ideal, but they need dextrose immediately. You can't give insulin to a euglycemic cat. You've got to give them some dextrose. And then you have to deal with the other stuff that goes along with DKA, like secondary pancreatitis or hepatic lipidosis. Now, my kind of recipe for treating a euglycemic DKA, and this is still a work in progress because veterinarians, we've got very, very limited experience. But first thing I would suggest is you give a bolus of 50% dextrose, and then go ahead and start on an insulin CRI at 0.1 units per kilo per hour. And then you need to match the insulin that you're giving with the dextrose infusion. And that's usually 0.25 to 0.3 grams per kilo per hour. You're going to monitor the blood glucose until it starts to rise again. When it starts to rise, you're going to turn off your dextrose as appropriate. You're going to keep an eye on what's happening to your BHB. And then you're going to transition the cat as you would do normally to a long-acting insulin. Now, we get lots of questions about diabetic remission for cats on SGLT2 inhibitors, and it probably occurs. It's just you don't know unless you discontinue treatment. Bear in mind that glycosuria can persist for a couple of days after you've stopped giving an SGLT2 inhibitor. So you really need to see if glycosuria persists for say, a week, and or check blood glucose concentrations, and that will tell you if the cat has or has not truly gone into remission. What I would say, though, is that SGLT2 inhibitors have cardiac and renoprotective effects, irrespective of diabetes mellitus in people, and have been used for those purposes in non-diabetic people. We don't know for sure if they are cardio-renoprotective in cats, but recognizing that CKD is a major killer of cats, if the cat is doing well on its SGLT2 inhibitor, the diabetes is under control. I'm not sure that I would rush to check for remission versus just thinking this drug could be very beneficial to a cat that's vulnerable to CKD no matter what. So to wrap things up, the SGLT2 inhibitors, they do offer new hope for newly diagnosed diabetic cats. These are oral medications with minimal risk of hypoglycemia. I would remind everybody again that patient selection is straightforward, but really important. You've got to kind of follow the rules about how you select a good patient. Routine monitoring is fairly simple, but is going to include the addition of surveillance for ketosis. Not every cat is an SGLT2 inhibitor cat. Some cats we're simply going to have to reach for insulin instead. And just published is a review article I wrote with the absolutely brilliant, I could not be more enthusiastic to have had this chance to work with the talented Dr. Ellen Behrend. We just published this in the Journal of Veterinary Pharmacology and Therapeutics. It is an open access article, and so if you take a screenshot, you can go to that web address and you can download this review. It's just a nice comprehensive review on how to incorporate these drugs into our routine practice with some nice charts on patient selection and monitoring. So now I'm done talking for a second. I'm going to ask Virginia to join me again for our Q&A.
Wow. Okay, first let me just say, wow, this is, first of all, it's so amazing because I've been in veterinary medicine long enough to have been in practice when uncontrolled diabetics were euthanized. There really wasn't, owners simply couldn't manage. And if we couldn't get them regulated, that was often the only option available. This is, and I don't use this lightly, this is game changing. It really is.
Yeah,
so yeah,
I share your enthusiasm. Yes.
It's just, again, yeah, I'm so excited for this for so many reasons. I also appreciate the fact that we're seeing a lot of human research applied to feline research and feline research being applied in human research as well, which that obviously makes every cat very happy. So I do have some questions. The first one I'm going to start with is a question that was actually sent in by email ahead of time. And she asked, is there anything recommended to help prevent infection or inflammation with diabetic cats? And what her example that she gave is that her cat went in for dental, had some tooth extraction, resulted in infection, inflammation, and about 2 months later was diagnosed as diabetic.
Oh, that's very unfortunate. Yes.
It is. After several months on insulin, though, she says on insulin, he is in remission. That's her term. So I'm wondering, is there anything, and it kind of goes along with another question that was asked, can stress hyperglycemia occur with a patient that's on an SGLT2?
Okay, so I'll try and address the first question first. I would tend to say for the unfortunate cat that became diabetic after the dental procedure, probably wasn't a ton that could be done to prevent that from happening. I mean, I think those usual standards of care as far as considering using non-steroidals for anti-inflammatory effect and then antibiotics after aggressive dental work. But I also think that sometimes we associate things and it was just more of a coincidental timing event. And so I tend to think about, does a cat become diabetic, as it's much like playing poker, and I don't play poker, so it's maybe not a great analogy, but you're given a couple of cards by your genetics. And so a lucky cat has one card of, say, a royal flush genetically. An unlucky cat has 3 of the cards for a royal flush genetically. And then the lucky cat gets some dental disease, but it's never that bad. But it does pick up 1 more card towards the royal flush, but still, that's it. Whereas the unfortunate cat picks up the final 2 cards with maybe being overweight and then having some inflammatory disease from dental disease. And then you've got the royal flush, you become a diabetic. And so I think there's that's how I think about it. You're born with a couple of cards, maybe 4 if you're very unlucky, or maybe none. And then you pick up cards during the course of your life. And in people say this idea about pancreatic resiliency being a bell curve. That's why some families, nobody ever gets diabetes. In other families, people who lived pretty healthy lifestyles still become type 2 diabetic when they're 60. And it's probably to do with inherited resilience. And then what you happen to be unlucky and pick up over the course of your life. And I've forgotten what the second question was, because I've got that kind of an old lady brain.
Any kind of supplementals, anything that you would.
Oh, it was a question about hyperglycemia with stress hyperglycemia. Yes.
Yeah, exactly.
So yes, a cat on an SGLT2 inhibitor could still get stress hyperglycemia. It might blunt a bit more quickly because they'll urinate out more glucose, but you can absolutely scare them into stress hyperglycemia. Yes, thank you.
And is that considered something that needs to be addressed, or with the decrease in stress, it will resolve itself?
It should, as soon as the cat is out of the stressful environment, it should sort itself back, just like we see stress hyperglycemia in non-diabetic cats. And so certainly that's why if you're rechecking, if you're doing, say, a 30-day, how are we doing? And the client is happy with how the cat is looking and your ketones are good, but your spot check blood sugar was 280, and you thought, that's a bit of a surprise. That might be a cat where I would just do a fructosamine, so I could really get a reliable assessment of, has this cat been euglycemic at home, and now I've just frightened it. Of course, it's going to be glycosuric no matter what, because it's on the drug, and so we can't use that as a marker for what my blood sugar was before I saw my doctor, because the drug is going to make you glycosuric, and so that would be a great candidate for just measuring a fructosamine.
So, and this, I think you addressed this, but this question was asked, the question's not crystal clear, but I think what we're referring to here is, her question is, would this be a replacement for insulin or in conjunction to achieve remission? And I think she's just referring to the SGLTs in general.
Yeah.
Do you use
so there have been some reports of using SGLT2 inhibitors along with insulin in cats that were very difficult to manage with insulin alone. The scary part about that is you really do run the risk of hypoglycemia. And so I think if you're, that to me would be a what I call fighter pilot medicine. And so probably would refer that cat to somebody who's got a lot of diabetic experience and could make that, that tweak. As a general rule, we should think of these as being the only drug that's given. I just think it's going to be complicated if we're trying to really finesse it. And so I would think about an SGLT2 inhibitor as being sole therapy. And as far as the remission, we'd have no idea how many cats on SGLT2 inhibitor go into remission, because if they're cruising at day 90, the blood sugar is 110, fructosamine is perfect, cat looks fabulous, but they've got glucose in their urine because of the drug. And so the only way we can tell if they've gone into remission is to stop the drug and give them a few days for the drug to wear off, and then see if blood glucose comes back to high again, or if they can maintain euglycemia. What I would say, though, is that makes me a little bit nervous, because we know from that hyperglycemic experiment that even a few days with the blood sugar over 450 hurts your beta cells. And so if you've got a cat who was had just enough beta cells to make enough insulin to do very well on an SGLT2 inhibitor, and so the cats that do well on SGLT2Is, they're making a little bit. They're not making enough. They're making just a bit, and that stops them from getting ketosis and lets them be metabolically very appropriate. And they're happy. They're happy on their SGLT2I and their little bit of insulin. And then if you take them off to see what's going to happen, and their blood sugar screams up to 450, those beta cells that you were counting on to do this might be gone. And now you might have created a cat who is now insulin dependent. And so to me, it's a little bit of a Russian roulette game. And I'm sure someone's going to do some studies and see what percentage of cats can be taken off of an SGLT2I, do go into a sustained remission. But my concern with that would be, wow, if you fail and you're not in remission, we might have actually just in 5 days have just tapped those few beta cells that we were counting on to make you a type 2 diabetic. We might have made you into a completely insulin dependent cat, and then we have really, really hurt you. And those drugs are so safe for long-term use, and the renal protective stuff is, I love to do a lot of nephrology in cats, and so really interested by the renal protective stuff. And so either the cat's in remission and doesn't need the drug, I'm okay giving it the drug because it could well be renoprotective, and CKD is still the biggest killer of geriatric cats, and we have no strategies really to prevent that. We just manage it as it appears. And so unless the cost of the daily medicine was really a problem for the average owner, I would say you're so much safer, just stick with it. Don't worry about remission. It's irrelevant if your cat's doing well. Keep with the drug.
And that kind of just dovetails into the question where it says if an owner abruptly stops giving an SGLT2 inhibitor because of compliant, whatever, will it be harder to regulate them if they restart?
It may well be. It may well be. Yeah.
Just answer that one. Okay. A question that I have is, you talked about the side effects, and you indicated that if a cat vomits once in the time period, which was 84 days, that was actually listed again as a side effect. And how do you assess realistically what to expect for side effects?
Yeah.
That's like
I know. I was actually surprised that in the 180-day study on the valagliflozin, only a third of cats vomited at least once. I thought my cat would have vomited, I don't know, 4 times in that time period. So yes. So when FDA studies, if the cat so much as looks at you cross-eyed, you have to make a note of it, and it has to be reported. And so to me, the vomiting really isn't a big deal. I personally knock that off as this is probably normal cat vomiting. If it's early on in the course of the treatment and the cat doesn't eat and vomits, I would think, is it getting DKA? And so particularly if it's not acting happy, if it gorged its breakfast, flung it up on your favorite carpet, and then asked for more, I would not be concerned. But if the cat, you woke up in the morning, there was vomit next to the cat and the cat didn't want breakfast, I would take that vomiting very seriously. The diarrhea is interesting because owners, certainly in the valagliflozin US study, were given the Purina poop chart, and every day, every poop, they had to describe every poop. And so half the cats got diarrhea. Often it was a stool that went from a 1 to a 2 or a 2 to a 3. And it usually was self-limiting. And I must admit, because half of cats are going to see a change in stool consistency, I think it's probably wise almost to tell the owner, expect to see a change in stool consistency. It tells us that the drug is working. Yeah. It's usually going to sort itself out. Now, if it's splattery diarrhea, obviously talk to me. But if it's you're bagging up that poop and it's like, oh, it's a bit squishy, but the cat's happy, then ride it out. It does seem as though the SGLT2 inhibitors do have some cross effect on SGLT1 in the bowel. And so particularly if you're on a relatively high carbohydrate diet, you don't absorb that glucose. And so it gets pooped out and it pulls water, so it will give you a softer stool. It seems as though the SGLT1s probably upregulate, so they seem to recognize that they're being a bit inhibited and they seem to upregulate. So most cats do seem to sort themselves out.
And this is my follow-up on that. I know in humans they talk about issues with slow motility, slowing the motility and causing constipation. Do you need to increase or
that's interesting. I've not read that in people in this drug class, but that's interesting if you've come across that. That was not a concern actually in the study. I don't think it was even, it might be somewhere on one of the information lists on did any cat get constipated, but it certainly wasn't a significant flag at all.
Okay. So
I think the cats would still, so when we're thinking about diet type, most of us are still defaulting to saying a low carb, high protein diet, and those usually are very, some of the diabetic diets have a bit more fiber. And so certainly if you think about the diabetic choices out there, the raw canning glycobalance has significantly more fiber than the Purina DM and the Hills MD. And so if GI transit and getting a sluggish bowel did seem to be an issue, then within the diabetic diet family, there are some choices that have a bit more fiber than others.
And onto that as well, a newly diagnosed diabetic that's been put on the SGLT2
inhibitors, it's a mouthful.
Do they still need a diabetic diet, or is it necessary to make
yeah, we don't know. We think yes. And the reason I would tend to say it's worth it. I mean, if money is tight, I would say focus on the drug, because the diabetic diets do tend to be more expensive, although a kitten diet is often a much less expensive option than a true prescription diabetic diet. And the reason for that is that cats on high protein diets tend to make more GLP-1, which is the really good incretin that helps nurse the beta cells back to life. And so because we're all about trying to keep your beta cells, do just need it just enough to stop you getting ketotic, anything we can do to pour love on the pancreatic beta cells, I think is worth it. And some of the data looking at diet responses in cats shows dramatically that they get a lot more GLP-1 produced when they're on a high protein diet. And so I still think that it makes sense to do that with our cats. But I would take 2 weeks to get them on the drug, make sure that they're eating and happy, versus dropping a diet change onto everything too, and then not knowing, is he not eating because he's ketotic? Is he not eating because he hates the food? So to me, it does make sense to put a pin in the diet change until you get through the first 2 weeks with your SGLT2I, and then sit down and think about a diet shift.
So this one's going to be a little bit longer, and I'm going to read the whole thing because this is about managing a diabetic. What do you do if your cat's glycemia fluctuates dramatically? For example, over 600 before an injection and 50 6 hours later on a normal dose of 2 times a day insulin. So she's been struggling 4 years to work with my cat. The vet has called her diabetes unstable. But I read that unstable diabetes has more to do with not being able to control it with ever increasing dosage, and the dose being 2 UI per kg or more, which she says we've never approached that level. Is her diabetes really unstable, or is there another term that's more appropriate for an animal whose sugar fluctuates wildly, but who responds well to insulin?
So insulin resistance is when you're on 2 units per kilo and your blood sugar stays over 350. And so that may be where that data point came from. So no, a cat is obviously not insulin resistant. And so I would use the term probably brittle diabetic, or we often use this term now, glycemic variability. And what your questioner is describing is blood sugar does this, and that's excessive glycemic variability. My first thought is this cat, my guess, is probably on Lente insulin. I've never been fond of Lente insulins in cats, to be honest. I'm going to upset whoever makes Lente insulins, but often we see that pattern in cats. Lente insulins have a significant component of a fast-acting proportion, so it will crash a blood sugar down. So my first thought when you see that is you're on the wrong insulin for your cat. That's my first thought, is you're on the wrong insulin type. You need to find a type that is much smoother, like Glargine, Toujeo. There's lots of other insulins that are much less likely to be associated with that degree of glycemic variability. But that to me is not the cat's fault. It's that insulin is just a really bad match for that cat's physiology.
So a recommendation would be discuss it with her veterinarian or ask for a referral to an internal medicine.
Yes. Try and find somebody who's got a love of the diabetic cat, because I think an insulin switch is probably going to be very, very helpful.
This will probably be the last question. If a patient presents to ER for DKA, is there ever a place to add an SGLT2
inhibitor? I would say no.
Discharged, or is this cat best kept on insulin moving forward if it's already been on insulin?
Yes. So the current consensus among those of us who know a lot about this drug is if you crashed and DKA'd and you had to be put on insulin, you're probably not a good candidate for an SGLT2 inhibitor. Now, I would also say that I recognize that for some owners, it's a conversation ends as soon as you say, and here is an insulin syringe, conversation ends. And so if somebody was prepared to treat their cat for DKA, but could not possibly give insulin injections at home, then I would say we have an option. And just the big uncertainty is what's going to happen. My fear would be if the cat actually DKA'd, then its residual beta cells might be pretty modest. Although we know historically that when we looked at cats going into remission treated with insulin, that having had an episode of DKA did not mean you could not go into remission. And so it doesn't mean that you've got no beta cells left. You may still have some beta cells left. And maybe if we do control blood glucose for you and let them wake back up, maybe you could do well on an SGLT2I. I think the current guidelines are if you've ever seen insulin, you should never use these drugs. And that's how the FDA is talking about these drugs. But I think as time goes by, there's going to be a lot of work coming out looking at specific categories of cats, like cats who DKA'd. Is it a legitimate thing to do? I think the one I'm very interested in is the acromegalic cat. I think this drug could be fabulous for the acromegalic. I'm sure people who see lots of acromegalics, the Europeans, where they seem to see tons of them, are already thinking about, collecting data for the acromegalic. Great for the Cushingoid cat because as you treat the Cushings, whether it's spontaneous Cushings and you're doing trilostane, or you made them Cushingoid and you're getting them off the pred, either way, you've not got to worry about hypoglycemia. And so I think there's lots of categories of cats that 5 years from now, we're going to have an awful lot more understanding of. But I just feel as though, and it's amazing, towards the end of my career, it's like, in a room I've lived in for a long time, the diabetic cat room, talk about them a lot, interested a lot, very comfortable. It's like somebody just found a new door and opened a new door, and now we're all walking through to this totally unfamiliar, undecorated, undefined space. And I had a strong sense that we don't yet know what is going to be and what's going to be possible, and where the boundaries and the limits and the caveats and the don't do it's really sit. And we do know it's a good choice for an awful lot of newly diagnosed cats, but not all. I mean, a fair number of cats failed screening. A fair number of cats in every study had to be removed because they didn't respond as well as we'd hoped. And so it's not for everybody, but it's really exciting. But it's like walking into a whole new space and trying to figure out, what we're going to put on the shelves and how we're going to use this room and what options we've got. But it is like, I think it's transformative. It really is.
And it's I'm personally looking forward to the protective, talked about cardiac and renal.
The renal protective. If this drug really does reduce the incidence of CKD in geriatric cats, that would be fantastic.
Well, I'm going to use that to say that's our last question. And with that, I'm going to transform into thanking our sponsor again, Boehringer Ingelheim, for making this webinar available to us. I also would like to say, I hope that you saw the screen in reference to your race CE. If you do need a CE certificate, please email me at webinars@everycat.org. I need your full name, your veterinary license, and the state of issue. And also, I want to, because of that, as you just said, all of the possibilities with this, Every Cat will be spending quite a bit of funding
that's great.
forward. So we appreciate everyone's support of Every Cat and its mission to fund feline specific health studies. And so if you are so inclined, if you want to hit the QR code and make a donation to Every Cat, we would definitely be grateful, because the only amount of money that we can contribute to funding research is money that's contributed to us. So again, Dr. Cook, thank you so much for your time. And I hope we can do this again in like 2 years and see where we've gotten to. I mean, I just think
Wouldn't that be exciting? Yes.
I know.
See how our whole new room is looking.
This is one of my favorite things about veterinary medicine, is it's never the same 2 days in a row. And just, I think back about so many things that have changed, and losing the diabetic cats because there was no option for them.
Well, yes, for me, the heartbreaking thing is some little old lady or little old fella who loves their cat dearly. It's their best friend, but you show them an insulin syringe and you say, you see that one? You see the one?
Yeah,
And it is impossible. It cannot be done. And so for me, yes, it makes me almost get tearful to think about people who love their cat dearly, but hadn't just simply couldn't physically treat a diabetic cat.
exactly.
And so many of those cats were lost, and it was just so heartbreaking.
And the one thing that we didn't even address too is, you know, in the past, that newly diagnosed diabetic, the glucose curves and the, you know, all of that added to so much cost that for a lot of people it was just beyond their pocketbook, and
Mhm.
they had to make decisions accordingly. So that was yeah. So excited. I hope we get together again in a couple of years and see what happens. Thank you
Oh,
again.
fabulous. Oh,
Thank you.
thank you, Virginia.
Thank you to everyone for attending. We really appreciate it. Thank you. Thank you.